I'm Scheffer Tseng, MD PhD, Medical Director of Ocular Surface Center in Miami. At the same time, I also serve as a Chief Technology Officer of Tissue Tech. My discovery of mechanical dry eye started over maybe 15-20 years ago. As I was recognized as a dry eye expert ever since I started my faculty position at the Bascom Palmer Eye Institute. And soon after, I began to see more and more patients with dry eye, and I realized there's a subset of patients that seems to fail everything I'm trying to do. That includes topical artificial tears, steroid, punctal occlusion, you name it. So they become a very interesting subset of population. And I look deeper into their problems, I realize they all have what we call today mechanical dry eye. Mechanical dry eye is a very important clinical problem. It is very prevalent. I would say in any regular clinical practice, average ophthalmologist will see patients with mechanical dry eye, at least a handful of them. So that is why it creates a frustration to most of the practitioners in dealing with dry eye. The reason mechanical dry eye differs from the traditional dry eye in many respects, because a traditional dry eye is known to have problems related to either compositional deficiency, such as aqueous tear deficiency, lipid tear deficiency, or mucin tear deficiency, so the component of the tears in trouble. And yet, mechanical dry eye patient does not have this problem. So this is not a compositional deficiency. And secondly, the conventional dry eye is known to have common problem inflammation. And anti-inflammatory therapies, you name it, from steroid, cyclosporine, and so on, they are directed to anti-inflammatory components. But mechanical dry eye patients, although they do have the inflammation, but the problem is not just inflammation. Therefore, it will not work and become very frustrating to treat those patients with conventional therapy. Then it turns out the mechanical dry eye problem is a mechanical factor. The problem rests in the deficiency for the tears to distribute through blinking to the entire ocular surface. That process, mechanical process, is in trouble. The wrinkled tissue disturbs the tear flow. Not just what people usually recognize at the lid margin, the tear flow being interrupted into the punctum to distribute throughout the ocular surface, but even more important is the lack of good tear flow distribution from the reservoir, that is the fornix, to the tear meniscus. And that action really requires a blinking to do. In patients with conventional dry eye, the blinking will help them because they do not have mechanical factor. In the patient with so-called mechanical dry eye, and sometimes we call conjunctival chalasis, this wrinkled conjunctiva, not just at the lid margin, meniscus, but also deep distribute to the entire fornix. That means now the tear fluid cannot be distributed to the entire surface. Therefore, the blinking does not help. And conventional dry eye, a patient use artificial tears. There is an intact sac or fornix, the reservoir, to hold the tears. And the patient with mechanical dry eye does not have this reservoir to hold the artificial tears. So not only the artificial tear, but also the patient's own tears. Therefore, they tend to have tearing, the overflow, and we call epiphora. And this is a very common paradoxical complaint. Why a dry eye patient all of a sudden complains of tearing? So I think the mechanical dry eye present a complexity and some of the paradox against what we know about the conventional dry eye. So mechanical dry eye, because of the problem is in the mechanical aspect of the tear distribution, I would then say the conventional treatment, I think artificial tear, anti-inflammatory therapy, punctal occlusion, all the things we generally use would not work on the patient. So my first recommendation is do not, particularly for those patients already failed this type of therapy, one need to think about mechanical correction. I think the first step is even before punctal occlusion is to consider surgical correction. So I think a procedure called reservoir restoration procedure will be the very critical to restore the patient's normal tear fluid dynamic. Upon the correction of this, actually all symptoms will resolve almost instantly, and all other treatments will be either eliminated, or if you need it, it will then work much better. For example, the artificial tears now can stay longer and then become more therapeutic. Punctal occlusion would do well in the patient with true compositional dry eye. Now you can use punctal occlusion to help patient because you have a reservoir to hold the patient's own tears to the point no additional therapy is necessary. And I'm very pleased to know today this has been recognized as an important potential contribution to the patient with dry eye. And I would strongly urge all our professional colleagues when you deal with patients with dry eye to be open-minded by thinking that those patients fail with conventional therapy. You need to think whether mechanical dry eye is an issue. And if so, I strongly also urge you to consider this simple procedure to correct the patient's problem. And I guarantee you, you will feel the procedure very rewarding, and so is your patient.